I'm a physiatrist. That's a doctor who specializes in pain, movement, and physical rehabilitation without surgery. And after more than 2 decades treating patients with chronic back pain, I want to share something I've watched happen in my clinic more times than I can count. Most of the people who come to see me have been living with back pain for years, not days, not weeks, years. And in almost every case, they've already been through the standard path. Anti inflammatories, maybe a round of physical therapy that insurance approved for 6 sessions, and some version of take it easy. Very few were ever told why their back hurts, the actual mechanical reason, not just the label on their imaging report. That's what I want to do today. I'll walk you through 5 everyday habits that are almost certainly making your back pain worse, not because you're doing anything reckless, but because no one has taken the time to explain what's happening inside your spine when you do them. Once you understand the mechanism, the correction becomes obvious. If you're over 60 and you wake up most mornings with stiffness or aching in your lower back, the kind that takes 20 or 30 minutes just to loosen up enough to move through your routine, you're in exactly the right place. I see this pattern every single week. Patients between 62 and 75 who have been managing chronic low back pain for so long they've started to accept it as a permanent feature of aging. They assume it's purely structural. They assume the imaging tells the whole story. By the end of this video, you'll understand the actual biology in a way that a standard 15-minute appointment almost never has time to cover. Here's what's actually happening in your lumbar spine, and why the diagnosis most people receive tells them very little about what to do next. When you get an MRI or an X ray at 65 or 70, the report almost always contains findings: disc degeneration, mild to moderate stenosis, facet joint changes. For specific clinical decisions, those findings matter, but here's what the report doesn't tell you. Research reviewed at institutions, including the Hospital for Special Surgery and cited by the American Academy of Orthopedic Surgeons, has found that a substantial proportion of adults over 60 with these exact imaging findings report no significant back pain. Meanwhile, some people with relatively unremarkable imaging are in daily pain that affects every part of their lives. Structural appearance is not a reliable predictor of pain experience. The pain is real, but its source is more mechanical and more modifiable than most people are led to believe. The mechanism most patients never hear about involves how your intervertebral discs receive nutrition. After your early 20s, those discs have almost no direct blood supply. That's normal anatomy, not disease. Your discs depend on a process called imbibition. Movement creates a pumping effect that draws fluid and nutrients in and drives metabolic waste out. When you restrict your movement, sitting for long stretches, avoiding certain positions because they've caused pain, stopping all activity during a flare, the disc loses hydration progressively. It loses height, loses its ability to absorb load, and becomes more vulnerable to the mechanical stresses that generate pain signals. The second mechanism involves fascia, the connective tissue wrapping your spinal muscles and running in continuous sheets from your neck to your pelvis. Fascia is designed to glide. When you restrict your movement for months or years, those fascial layers develop adhesions. Think of plastic wrap pressed together for too long. Every time you move after prolonged stillness, you're peeling those layers apart, and that generates its own distinct pain signal. In many patients, what they interpret as structural damage is largely this: restriction that has been in place long enough to become structural adhesion. The third mechanism is muscular. The deep stabilizing muscles of the lumbar spine, the multifidus, and the transverse abdominis are designed to activate before you consciously initiate movement. In people with chronic back pain, they stop firing reliably. The body shifts load to larger, less precise muscles that fatigue faster and ultimately increase mechanical strain on the structures they were meant to protect. A spine that is both painful and mechanically less stable than it should be, and none of that appears on imaging. The most damaging belief I encounter in my clinic is that chronic back pain requires rest and avoidance. For acute injury with active neurological symptoms, rest has a specific and appropriate role. For the recurrent, dull to moderate low back pain that adults over 60 deal with daily, prolonged movement avoidance is among the most counterproductive decisions a person can make. The disc dries out, the fascia adheres, the stabilizers weaken. Each cycle of pain and avoidance creates the conditions for the next one to be worse. Here are the 5 specific habits that keep this cycle running. The first habit is sitting for 90 minutes or more without changing your position. Sitting doesn't feel like a risk. You're not lifting, not twisting, But for your lumbar spine, sustained static loading is one of the most mechanically stressful states your disc can be in. Intradiscal pressure in prolonged seated posture is measurably higher than in standing, and without movement to drive fluid exchange, the disc loses hydration at a rate that compounds over the course of a day. Research supported by the American College of Occupational and Environmental Medicine has identified 90 minutes as the threshold after which this compressive load begins to have measurable negative effects on lumbar disc tissue. The correction requires no equipment. Every 60 to 90 minutes, stand, walk for 2 minutes, and if pain allows, add a slow, controlled, gentle backward extension, hands on hips, nothing forceful. That 2 minute interruption resets the pressure gradient and restarts fluid exchange. Patients who make only this change report meaningful reductions in afternoon back pain within 2 to 4 weeks. Set a phone timer if needed. The second habit is bending forward to reach low objects without using your hips. Refrigerator shelves, the dishwasher, a laundry basket off the floor. These reaches happen a dozen times daily without conscious attention. Adults with back pain develop a persistent compensation. They reach with the back, legs relatively straight because bending the knees takes effort, and the spinal movement feels more natural. Mechanically, this creates a shear force through the lumbar discs at full arm extension, and the disc absorbing a lever force, not a direct compressive load. Repeated dozens of times a day over months and years, this is a significant source of cumulative microtrauma, entirely invisible on any imaging report. The correction is hip hinge mechanics, bending at the hip joint with the spine held in a neutral position rather than bending through the waist. About 1 week of deliberate practice before it begins to automate. Practicing once in front of a mirror is worth doing. Once you see the difference between the two patterns clearly, the compensation becomes easy to recognize and interrupt. The third habit is side sleeping with no support between your knees. Side sleeping is generally well tolerated for back pain because it reduces lumbar extension and unloads the facet joints. The problem is positional. When the top knee drops forward toward the mattress, as it naturally does with nothing supporting it, it creates rotational torque through the pelvis and lumbar spine that is sustained for 6 to 8 hours. The muscles at the back of the lower spine maintain a low level contraction throughout the night, resisting that rotation. They are not recovering. By morning, they're fatigued, shortened, and generating the deep stiffness that makes the first steps out of bed feel like negotiating with your own skeleton. A pillow positioned between the knees, sized to keep the hips stacked and the pelvis neutral, eliminates that rotational force. This is standard guidance in formal spine rehabilitation protocols. It costs nothing and takes 30 seconds to set up. Patients who add this alongside minimal morning movement typically notice reduced stiffness intensity within 10 to 14 days of consistent use. The fourth habit is stopping all movement completely on high pain days. The instinct makes sense. Pain is the body's signal to stop. But for chronic recurrent back pain without acute neurological signs, complete immobility during a flare is one of the decisions that most consistently prolongs it. When you stop moving, fascial adhesions progress more rapidly. Inflammatory byproducts accumulate in compressed tissue with no circulatory clearance. Stabilizing muscles lose activation cues and weaken further. Patients regularly report feeling worse the morning after a day of total rest than they would have with gentle movement, and the flare lasts longer. What the evidence supports is strategic gentle movement on high pain days. 5 to 8 minute slow walks, careful pelvic tilts lying on your back with knees bent, gentle supine knee to chest holds, not rehabilitation exercise, just movement sufficient to maintain circulation and fascial gliding without adding mechanical stress to already irritated tissue. This distinction between complete rest and strategic gentle movement is one of the most clinically important things I can communicate to a patient with chronic back pain, and it almost never gets adequate time in a standard appointment. Before I get to the fifth habit, if this kind of mechanistic evidence based information is useful to you, the kind that typically doesn't fit into a 15-minute visit, please hit the like button and subscribe. Every share and comment puts this content in front of someone else who has been managing pain for years without a real explanation. This channel is made for them. The fifth habit, and the one with the most far reaching mechanical consequences, is sustained forward head posture throughout the day. Most people think of this as a neck problem. It is, but it's also one of the most consistent and underappreciated contributors to lower back pain. Your spine functions as a single connected mechanical unit. When your head drifts forward, looking at a phone at lap level, reading flat on a table, working at a monitor that's too low, your cervical spine compensates by extending at its base. The thoracic spine rounds further forward. The lumbar spine then compensates by either exaggerating its inward curve or flattening it, depending on your body's particular pattern. Either way, load distribution across your lumbar discs is disrupted. You're placing mechanical stress on structures not designed to carry it in that configuration, and doing it for hours at a time. The correction is not effortful straightening. Effortful postural control produces muscular tension and fatigues within minutes. What works is a brief daily reset: chin retraction, shoulder blade retraction and mild lowering, and a short thoracic extension over a rolled towel or firm chair back. 3 minutes once or twice daily. Research in physical medicine literature has consistently identified daily postural reset as among the highest leverage interventions for recurrent back pain, precisely because it addresses the compensatory chain at its source, rather than treating the lumbar segment in isolation. Now, I want to speak to something I changed in my practice a few years ago because it connects directly to why knowing about these 5 habits isn't always enough. For most of my career, my position was firm. If a patient needed structure, a sequence, a day by day progression, I referred to physical therapy. I would not have considered recommending any digital format as a substitute. My concern was specific: patients over 60 exercising without clinical supervision, without anyone to identify compensations before they become injuries. I had seen patients follow generic online guidance without progression logic and worsen their symptoms. What shifted me was not enthusiasm about digital health. It was arithmetic. I started examining how many of my patients over 65 were actually accessing the physical therapy I was prescribing. The number was lower than I wanted to believe. Medicare Advantage plans were approving 6 to 8 sessions when the research supported 12 to 16 for durable results. Patients lived 45 minutes from the nearest rehabilitation facility. Others couldn't get there twice a week without depending on family members. I was recommending a solution that worked for patients who could access it and offering nothing to those who couldn't. So I looked with considerable skepticism for a structured program built specifically for this population: older adults who needed stepwise progression that wouldn't move from day one to movements they weren't prepared for, and explicit guidance for elevated pain days rather than only ideal condition days. The program I now incorporate into my recommendations includes a spine decompression sequence, low load controlled movements that create gentle traction through the lumbar and thoracic spine. Controlled movement in specific planes generates the pressure differential that encourages disc rehydration and promotes gliding between fascial layers, the same mechanical principles behind manual therapy techniques a physical therapist uses, performed independently on a mat at home in under 10 minutes with modification guidance for elevated pain days. It also includes a daily postural reset sequence that maps directly to the 5th habit. Rather than asking patients to consciously correct their posture throughout the day, the sequence builds the neuromuscular cues that allow postural tone to reset automatically. That distinction matters considerably for adults over 60 because effortful, attention dependent correction fatigues quickly. Lasting change comes from repeated low effort input that gradually restores reflexive activation patterns. What I've observed, speaking only to what I've actually seen, is that patients in the 65 to 74 age range who engaged with this kind of structured progressive approach consistently over 4 to 6 weeks showed meaningful self-reported reductions in morning pain intensity and in the time needed to reach comfortable functional mobility after waking. Not every patient, but consistently enough across the profile I described at the start of this video that I've maintained this as a recommendation. To be direct about its limits, this is a structured educational program, not medical treatment. New neurological symptoms, pain that wakes you from sleep, unexplained weight loss alongside back pain, those require individual clinical evaluation. For someone over 60, already evaluated, no red flags, managing recurrent low-grade to moderate back pain and looking for structured daily guidance, it addresses a gap the current standard of care often leaves open. The link is in the description if you'd like to look at the structure at your own pace. Here's the longer view, because I think patients deserve to understand what happens when back pain is left unaddressed over years. When pain drives you to limit movement, the lumbar spine is not the only structure paying the cost. Your hip flexors adaptively shorten and pull the pelvis into anterior tilt, loading the facet joints in ways they weren't designed to sustain chronically. The gluteal muscles lose activation from disuse. The hamstrings compensate. Over months, you're managing not just back pain, but hip discomfort, anterior knee aching, plantar tension, a distributed symptom pattern that makes recovery slower and more complex than it needed to be. This is why, in my clinic, back pain at a certain duration is rarely treated as an isolated regional problem. What I'm addressing is the compensatory movement pattern that has been rebuilt around the original pain source. Longitudinal research consistently finds that the most reliable predictor of sustained functional independence after 70 is not blood pressure control or cholesterol management, it is mobility. Can this person rise from a low chair without pushing off with their arms, carry a grocery bag while walking with normal gait, manage a flight of stairs without holding the railing, recover from a stumble without falling? These are the functional benchmarks that distinguish adults in their mid 70s who are living independently from those who are not, and precisely the benchmarks that progressive movement restriction erodes slowly and often invisibly. I can tell within 90 seconds of watching a patient walk into my exam room whether they've been moving consistently for the last 2 years or managing through avoidance. In the mid 60s, the difference is still meaningfully reversible. By the mid 70s, it is visible in gait, in sit to stand mechanics, in posture, and in response time. The patients who kept moving, might be even imperfectly, even on uncomfortable days, present as a fundamentally different clinical picture than those who stopped. To bring this together, we covered 5 everyday habits that place cumulative mechanical stress on the lumbar spine: sustained sitting without position change, forward bending without hip engagement, side sleeping without knee support, complete rest during flare ups, and sustained forward head posture with its lumbar compensation chain. Each has a clear biological mechanism. Each has a practical correction that requires no equipment and no commute. The goal isn't perfection across all 5. The goal is reducing the repetitive mechanical load that keeps the inflammatory and fascial restriction cycle running. Tell me in the comments, which of these 5 habits do you recognize most clearly in your own daily routine? And how long have you been managing back pain without a clear explanation for what's actually driving it? One more thing before I close. Fascia loses elasticity through both age and disuse simultaneously, meaning every year of continued restriction starts the restoration process from a lower baseline. That is not a pressure tactic. It is what connective tissue physiology demonstrates. The window in which movement produces its most responsive results is more accessible today than it will be in 2 or 3 years of further avoidance. The program I mentioned is in the description. It provides the changes I described and related ones in a day-by-day format with a progressive plan and a tracker, so you can see whether what you're doing is producing results. Look at the structure and decide whether it matches your situation. And what I'm sharing in this video is education, not a personal diagnosis. If you have a specific spinal condition currently under active treatment, stenosis with neurological symptoms, osteoporotic compression fractures, an inflammatory spinal condition being managed by a specialist, talk to the physician who knows your history before changing anything in your daily movement pattern. The link is in the description and in the pinned comment below. The patients I have seen maintain the most function into their 70s and 80s share one consistent characteristic: they never completely stopped moving, even during the hard weeks. That's not a motivational observation, it's a clinical one. The tissue requires input. Starting that pattern today costs far less than starting a year from now when the baseline is lower.